David Rapkin at Psychedelics today, being joined by the team at NueLife. And maybe while we're waiting, Ben, Lauren, and Lynn Marie, let's just talk about where we are in the world before we kind of get into the nuts and bolts. So I'm David. I am in Teaneck, New Jersey.
Oh, my mic's the only one on still on. I'm Lynn Marie Morsky. I'm in San Diego, California.
I'm Ben, and I'm actually in New York City.
I'm Lauren. I'm in Ventura, California.
Lovely. So two Californians and two East Coasters. All right. Hello, everyone. So yes, my name's David Drapkin. I am the Director of Education and Training at Psychedelics today. And today we are joined by some of the leadership team at NueLife. I'd like to introduce, first of all, Lynn Marie Morsky. She's the President of the Psychedelic Medicine Association, host of the Psychedelic Medicine podcast, and Medical Director at NueLife Health. Welcome, Lynn Marie. Awesome to see you. And Ben Medrano, Medical Director of NueLife Medical Group. And you may have seen or listened to our podcast from Tuesday. It came out, so 2 days ago. So if you really like how Ben and I speak, then you can go and check out that really cool podcast. Thanks, Ben. And Lauren Marchevka is the Senior Medical Provider at NueLife, and she's a board certified family nurse practitioner. So that's us. Welcome. So why are we here? I can answer that one, and then it's over to you three folks. We're here to learn about NueLife. We're here to talk about science, research, real world evidence of what happens when thousands of people use ketamine at home with the clinical protocols, with all of the kind of team building that NueLife has done to get treatment for a number of different indications. What is that like? This is really brand new, just the last year or two. So we want to hear all about it. And I want the three of you, please, to be super honest. So this isn't a sales pitch. It's not a podcast. It's really talking about like the nuts and bolts, the nitty gritty. What have you learned? You know, what works, what doesn't work? What have you tweaked? What have you found is kind of the magic sauce? Let's really talk about it because there's tons of questions, and folks, please pop them in the chat. Let's really figure out like, how does this work? What is it like? So I think a lovely place to start is, what is NueLife? Where did it come from? And kind of who is there within the team? If one of you could just introduce us, please.
I'm happy to maybe talk about it from the medical group side and then leave it to Lynn Marie to talk about the broader organization. And I'm actually sort of curious, as you were asking that question, David, to hear Lauren's thoughts about doing this work as well, because she's been around for some time doing some home-based ketamine work. So, but to start on the medical group side, well, what is NueLife? It is a group of prescribers, mostly nurse practitioners, some PAs, and a handful of docs who are working together to bring ketamine to people at home. Now, that's the medical group side. We do have therapists, or integration specialists is actually what we have. So, and these are, some of them actually do have some therapy background, some don't. And they provide integration in a group format. We also have health coaches who do one-on-one health coaching. And we do all of this through our teleplatform. So that's sort of the gist of the services, the team that is bringing this forth. And there's a lot more to it, which I'll hand over to Lynn Marie to say.
Thanks, Ben. Well, one thing about NueLife is that we're not a ketamine company. We use ketamine as a way to reset people. A lot of mental illness comes from us getting kind of stuck in that rut. A lot of us have heard about this default mode network, and it gets stuck in these ruts that are negative self-talk or repetitive thoughts or trauma. And ketamine is a great way to reset. But we wanted to use it as a reset and then continue to support you in your lifestyle behaviors that will foster ketamine having more of a durable effect. And so that's why, like Ben was saying, we have health coaches, we have preparation, integration, because ketamine is just one tool that we use in a larger pool of like a larger toolbox. And we really emphasize the fact that the aftercare is important. We don't want people to be reliant on ketamine. If they need a booster every so often, great, but we want people to develop new patterns and new habits and lifestyle changes that can be durable. And so to round things out, to have something as large as NueLife, we're nationwide, and to keep it safe, we have things like patient safety and compliance officers. We have a general counsel from BetterHelp. She used to work at BetterHelp, who I know we've all heard of, right? Because we're a large telemedicine platform company, so it's great to have fantastic legal support. And then we have amazing people on our welcome team that do the intro calls. That takes a lot to, if a lot of you are wondering where you might fit in the field, even just dipping your toe in with places that have people doing the welcome team calls, they're doing a lot of the mental health work, right? They have to hear the patient's stories and listen to the patient's concern. And that may be something that's a great way to start realizing, like, is this a field I want to be in? Because that's what our team is doing day in and day out. And then on the back end, we've got great people in advertising. And then the things that I really are close to my heart is our tech and data side, because we've done over 45,000 ketamine experiences, and we have this amazing technology, and you put those two things together, and that leads to data and trends. And we just recently put out a study, and all of that helps us refine our process, and also helps the sublingual ketamine field as a whole know better about what we're doing right, what we could change, and how this can be helpful for patients.
Just add in there, since we covered the whole gamut of the team, there was one member I think that is important to also highlight is our client success managers. And so when we look at the actual technology that we started to refer to of this app that is really the interface with the entire team, that you have this sort of one person that's following your entire healing journey and coordinating all of those providers through that app. So everything that you do, all your appointments and everything is done through the app, as well as your experiences. And within that technology, we also have our own music platform, which is curated for people's moods, so what kind of journey that it is that they're going on or what they're focusing on. But maybe Lauren, if you want to speak a bit about your experience.
Yeah. So, I mean, for me, NueLife is really just this tech-based platform that really provides hope. And it is so incredibly affordable compared to what in-person ketamine treatments would be. And we're accessible, right? So a lot of people who really, really need help can't afford or can't travel to clinics to get the help that they need. And so really NueLife is creating this beautiful, comprehensive opportunity for people to actually feel better and to do it in like the safety of their home. It's, coming from working in person and like helping people kind of work through this journey, and then transitioning to the virtual platform, I was a little apprehensive. I wasn't sure I was going to be able to really connect with the patients on the same level, because I love to hold their hand and I love to hug them and cry with them. But wow, I am just blown away by like just reading what they say to me in the chat. And then like when we have our one-on-one videos, it's truly amazing to watch people go through this transformation. So I'm just so incredibly grateful that we exist, that NueLife is a thing, because we have just changed so many people's lives, and it's just such a good feel-good feeling,
Beautiful. Thank you, the three of you, for going into that level of detail. Really positive. And I love how you said, Lauren, it's a company of hope, and the work is full of hope. And that's actually what Ben mentioned on Tuesday from his experiences at Wonderland in Florida. Lots of, discussions and debates and disagreements in the psychedelic space. But one thing, hopefully, that fills us with unity is around the hope for what psychedelic medicine, treatment, healing, research can offer. So I've got a question about ketamine, but I also wanted to say, I know Ben and Limmery, you're both quite musical, Limmery on the drums and Ben back in the old days as a DJ. So what's been your experience with helping with the music playlists that you're developing? And each medicine has a different kind of feel for it. And if a client is going through the NueLife kind of music journey, how have you created that? And are there different kind of ways of optimizing it? Just as a little tangent going that way.
I'm happy to talk about more my experience of using it than actually designing it because I had little involvement in that. I mean, well, first off, when we were putting together the team to do this, we wanted to make sure we had one of the most skilled people to creating playlists. So we actually brought over a former founding team member of Pandora. And so they really helped us with the beginnings of curating this. And so what a musicologist does is still somewhat beyond me. I don't know if I could say much more to it, but my experience of it, and so the the sort of side benefit to working at NueLife is that you got to understand what the protocol is, and so many of us have actually experienced it, and so I've gone through the protocol to understand, well, what is it like to experience the app and with the medicine and so on. And you know, when I was initially getting involved, I thought of myself as, you know, very nitpicky, like a particular, like I was very particular about what kind of music should be played during a journey. And I was pleasantly surprised by the spectrum of options. The sort of thoughtfulness of the selection of music was in line with a lot of the research that I've seen around psychedelic music, which is, you know, less sort of less vocals, um, less familiar content in general. I would say the majority of tracks that I've heard, if not all of them, I've never heard before. And I think that's really helpful to allow oneself to let go into an experience and not get too hinged or on something that sounds familiar. So really happy with the way that that aspect of our tech is designed.
Yeah, I also find that, you know, when I'm counseling patients on the app, I say it's so awesome because this musicologist basically cultivated these beautiful playlists that correspond to intention. So if you like put in a certain intention, it'll give you a preset list of playlists to choose from. And then if you change it, it'll give you a different preset playlist, which is just awesome. So I always recommend that the patients listen to it first, so they have access to the app before they actually have their journey. And I think that's so important since the music is, you know, it's kind of like the conductor of the experience in some ways. Like if you are listening to the music and there's something that doesn't resonate with you, like it's greater to send you down a journey that maybe aren't really open to happening at that time. So I always say, listen to the music first. Make sure it really feels good, that you can envision yourself really relaxing or whatever your goal is for the journey. And if that kind of pairs with that, then go for it. And then I also tell patients too, like if you listen to all of the playlists and nothing really resonates with you, like you can create your own playlist. And then we go over things that, you know, might be important, you know, and thinking about how the music makes them feel in that moment. And, you know, what do they want their journey to take? Where do they want to go with in their journey, basically, with the music?
Hmm. Yeah, thank you. And you know, ketamine is a different experience to say psilocybin or MDMA, and the intention is definitely a key part of that. So I love how the music's going to need to be different and lining with the set and setting there, and trying to get a sense of what is ketamine. So literally, like, what is it? We could think about its molecular structure. We could think about kind of its kind of route of administration. We could think about its kind of mechanisms of action, and its kind of feeling and functions and outcomes. So before we kind of move into the operationalizing of how you have used ketamine and built it into your other kind of holistic services, can we just clarify, when we talk about ketamine, what is it that we mean, and what is it that NueLife is using ketamine for, and what kind of ketamine?
I'm happy to take routes of administration, then I'll throw it over to Ben for the molecular discussion. So ketamine was first created as an anesthetic, and it was used in the battlefield, and it's got a long history of use as an FDA-approved anesthetic. And in the period of time that it's been out, a number of formulations have come up. I'm going to list as many as I know. There may be others. There's intravenous, there's intramuscular. And so intravenous is you've got an IV in, you know, you've got like a stream coming in. Intramuscular is when you get a shot, and that generally gives you the entire dose. So there's kind of like hybrid pulse dosing ways where they give multiple shots, but generally it's, you get one shot and then you have the ketamine in you. There are oral versions, and then there are sublingual versions, what we give as a sublingual rapidly dissolving tablet. There are also lozenges, which some people call troches or troches. I've heard it pronounced 17 different ways. And then there are some more obscure ways. There is rectal ketamine. I have heard of vaginal ketamine. There is topical ketamine. So there are a number of different routes of administration, and I will pass it over to Ben for more.
Yeah, as a caveat to that, I'll say that all of those different routes of administration for people who have experienced them, they will tell you that their experience of them is almost like a different medicine altogether. The experience of the rate of onset really does play a role in how the trajectory of the journey is going to evolve. So when you hear people who have done higher dose intramuscular ketamine and have done sublingual, they'll say these are like two completely different experiences altogether. And even if you try to do the conversion or like sort of the based on bioavailability, like how much of the drug is actually converted, even if you try to make them equivalent between sublingual and intramuscular, it still ends up being a different experience altogether for people. And the way that people will describe that difference is that the intramuscular has a higher likelihood to really be like a transpersonal experience. You'll hear more reports of sort of ego dissolution occurring or out of body experiences with intramuscular. It's not as if it doesn't necessarily happen with sublingual. I mean, those things do happen with sublingual, but the quality is there is a higher degree of intensity. And I think a lot of that has to do with the rate of onset. But then there are just other aspects we really just don't understand. So the molecule of ketamine is an NMDAR receptor antagonist. So what does that mean? That means it's blocking the NMDA receptor. And the downstream effects of that is ultimately to increase glutamate in select areas of the brain. Now, we've learned over the last couple decades that glutamate actually plays a greater role in depression than we once thought. It is probably one of the most ubiquitous neurotransmitters in the brain. It's got all kinds of activities, and it's more broadly found throughout the brain than serotonin and so on. So a lot of new sort of NMDA drugs like that are affecting that receptor site are coming out with the intention to try to address the unmet needs that have been revealed by the shortfalls of serotonergic antidepressants. Now, what are the downstream effects other than glutamate? So glutamate helps regulate neuroplasticity or new nerve growth, and it's done through a receptor site AMPA and a neurotransmitter known as molecule known as BDNF, or brain-derived neurotrophic factor, and that actually stimulates new nerve growth as well. So that's one proposed mechanism of how ketamine is working, is through this sort of neuroplastic route and also through glutamate regulation and its effects on mood. But there are some other mechanisms that are proposed, and one is its anti-inflammatory effects also happens down the glutamate pathway. And then another is just looking at neural networks and seeing what happens to those when you look at an fMRI. In particular, a lot of research that you see around psychedelics revolves around something that's called the default mode network, or DMN for short. And that network is commonly described as sort of a monkey mind, if you were to use some Buddhist terminology, which I tend to fall back on. But really, it's the mind, the wandering, daydreaming mind, or the neurotic, self-oriented mind that really tends to not be in the present moment. Frankly, that's like the easiest way to describe it. It's just the mind that's not necessarily present. And so we find with psychedelics, and ketamine is included on this list, that network is downregulated, meaning it is sort of held back a little bit. And what do we see? We see people, the areas of the brain that come online are the areas that have more to do with being present, with actually not only being present, but the areas of the brain that are normally repressed. So when we think of like this old lizard brain, or the brain that sort of is driven by reflexively by traumas out of fight or flight and so on, that those areas, the brakes are somewhat taken off on those areas a little bit more, so that some of that kind of processing, traumatic processing, can begin to take place as well. And there's a lot more to all of this, like such as you will see that people from engaging in the networks in the way that we described will begin to have more frontal regulation or more impulse control. So we'll see sort of growth in those regions as well. And it's akin to a lot of the research that you see around meditation. It's really interesting to look at the parallels of all the research on mindfulness and the research on psychedelics and ketamine in particular. There are a lot of them. So I'm not suggesting that people should not meditate. I think that they are wonderfully complementary, but in some ways there's a little bit of biohacking that goes on with the use of ketamine that sort of can yield similar results to long-term meditation.
And can I just jump in here and correct something? An omission, I left out nasal ketamine. So when you post this on YouTube, nobody who's a nasal ketamine doc's like, what about us? So sorry. Thank you, Ben, for that amazing description. And yeah, just know that I think that covers most of the routes of administration.
Thank you for that. That really good to note. Part of what we're saying here is we know something about how ketamine works, but there's still a lot we don't know. And I'm looking forward to hearing more about the research that you've done and other folks' research. I just want to add something for people that are watching. Ketamine, like Leah Marie said, has been used for decades. It's, kind of think a World Health Organization required medicine, been used a lot on the battlefield for pain. It's one of the most commonly used medications in a emergency department with adolescents and adults for pain and anesthesia. And they found that a lot of patients that were waking up from anesthesia that had depression before their surgery actually noted that following the surgery, their depression had gone because of the ketamine. So that started off this whole interest around what is it that ketamine does that helps with depression. And it started off with IV ketamine and, clinics opening up and specializing in that for depression. Could one of you talk to us about why NueLife is so focused on just the at-home model, not say opening up clinics doing IV or IM or ketamine-assisted psychotherapy in a kind of clinical, physical model? What is it about the at-home model that really resonates?
I'm happy to take this one. So we have great, we've loved partnering with ketamine clinics across the nation because in-person ketamine definitely addresses a certain level of acuity. There are certain conditions that should only be treated with in-person ketamine and not at home. However, there are many more that can be treated at home. And the cost for in-person is very often prohibitive for a lot of these patients that might be able to benefit. And so at home solves the problem of the cost being too high, and then also geographic limitations. If you live 2 or 3 hours from the nearest ketamine clinic, that may not be a very realistic plan for you to go 6 times in 3 weeks or whatever the typical course is. And so that's what NueLife wanted to do, is we wanted to bring healing to people that weren't being served by these other, we're glad that there are a number of really high quality in-person ketamine clinics, but for us to just be another one of those still leaves that same segment of the population out. And so, our entire founding board was women and people of color. And a lot of the ethos was, how do we get to the people that can't afford or don't live in big cities and don't have the expendable income? We know that ketamine is generally not covered by insurance. And so people are paying out of pocket, $5,000 and $6,000 for the in-person treatment sessions or courses. And again, we really wanted to help the people that wasn't accessible for. Accessibility is such an important issue for us. We wanted to target populations that weren't able to get to the healing before. And so that's why we focused on the at-home model.
And I just want to piggyback off of that. For my patients that have done ketamine in an IV center or, with their psychiatrist, a lot of them really prefer the at-home model because they're in their own home. They get to kind of create their own little healing space. They're not hooked up to a bunch of monitors. People aren't watching them. I feel like in some ways they're able to really let go a little bit easier. There's a little bit less kind of like stress and anxiety around the experience, because they're not, in like a medical setting where they're feeling like, someone's just watching them all the time. So it's really nice to really give them an opportunity to do it at home and to feel safe with their sitter and that person that's supporting them. It just kind of creates this really beautiful healing journey. And so overall, a lot of my patients that have kind of done both really prefer the at-home model, which is awesome.
I'm really glad you brought up, Lauren, that the sort of side benefits, actually unexpected benefits for some patients, especially patients with anxiety disorders, or maybe even who are developing some agoraphobia, that this allows ketamine to be more accessible to those populations as well. I mean, coming from a community psych background, it had always been on my mind, and David and I were talking about this on the other podcast, is, when we think of accessibility, in the system that we have in place right now, as Lynn Marie stated, we can't necessarily get this covered by insurance just yet, but what we can do by piloting out these models like we're doing is demonstrate the safety and the efficacy of them. And so, yes, we've brought down the cost by 70% of most ketamine services, which I think we should be very proud of, but that's not the end of it. We need to keep moving forward. And a big part of what this company is trying to do is bring forth that data in an open source manner so that we can actually validate that these treatments should be covered by insurance. And we have some respectable people on our advisory, including one of the former medical directors or chief medical officer of Medicaid. And I think having those kinds of people on board giving us advice is really a clear indicator that there is a positive trajectory towards accessibility taking place here. And I think there's a question even in the chat box about maybe, I don't know, David, if you think it'd be good to talk about this right now, because I think it's a really good question.
Yeah, go ahead, Ben. I see that too. So someone asks in the chat, do you have any concerns regarding ketamine abuse with home-based administration, which is unsupervised, is the question.
Absolutely. Thank you, Carlos, for asking that. So safety for all of us, first do no harm. We all took that oath, and it was definitely top of mind for any of. I'd be surprised if there is any company that isn't thinking about this in regards to ketamine, who are trying to do home-based services. But for us, we take it very seriously. The reality is that ketamine does have a small abuse potential, and that is undeniable. We know that ketamine addiction is something that can occur. Now, in the research, we actually know with a great deal of confidence that it rarely occurs when under proper clinical supervision. So the kind of ketamine abuse, misuse that you're seeing right now in the recreational, I hate using that word, by the way, and more the exploratory community, because there may be many people here who are trying to explore. But for those who are using it there, we're seeing mostly intranasal, and the kind of abuse that you see occurring there are people that are using a gram or more a day. And so when you start to think about all of the other physiological harms that can occur, such as the cystitis, like bladder irritation or bladder inflammation, it generally only occurs in those populations that are using it in high use. Now, we did see a little bit in research some addiction occurring with intranasal ketamine sprays that are being prescribed for at-home use, not the Spravato REMS monitored risk mitigation monitored intranasal, but there were people who were compounding and still are compounding intranasal sprays with generic ketamine. And we started to see some people starting to get hooked on those in that way because of the ease of use, to be able to just sort of self-titrate. there are benefits to that self-titrating, but it's actually not the route of administration that we recommend or use for home-based services. Lozenges, uh, they can't really be crushed and snorted. I think if any, I mean, one could try, but I think it would be probably a very frustrating experience for people. And also there's a lot of experientially for people doing lozenges and like who may want to go out to a party and do a lozenge. It's not really sort of made in a way to facilitate social interaction. So if you wanted to abuse it, like go to a bar, you're going to have to hold it in your mouth for 10 to 20 minutes and swish around saliva, and it's quite I would imagine it's a very awkward experience. So there are a lot of things that sort of prevent the abuse from occurring other than good medical monitoring. It's just the way it's even being delivered. So it's less of a concern. It's not something that we really see in our patient population.
And I'm happy to expound on that with some of the safeguards that we've got built in. And referring to the awkwardness of swishing it around your mouth, we actually do rapidly dissolving tablets. And our CEO the other day was talking about how they have sea salt in them, and he's heard that that is extremely corrosive if you try to snort it. And so if you try it once, you're probably not going to try snorting our product again. So short of that, we have been really intentional about the way that we've set up our distribution. So if you're doing our plan that has the 6 doses, which is kind of our standard plan, you get 1 dose sent to you, and then you report back, and then the clinician, somebody like Lauren, will speak with you, and they, you fill out a little experience tracker, and then they will adjust the dose, and then they send 2 doses. And then the same thing is you fill out the experience tracker, and then they send you your last 3 doses. So you're never in this 6 series getting more than 3 doses at a time. So it makes it hard to abuse, because you would be done with your, you'd eat it, use it up very quickly, and there'd be nothing more to abuse. And we don't just send you, ad nauseum ketamine. We have a very specific plan. And also to make sure that you're taking the ketamine that we sent you in the right way, our app has this feature where before you do the experience, first you do have to take a picture with you and your sitter, which is another safety protocol, but you also have to take a picture of the dose and enter the lot number. And so we're tracking this. So this is not another point is the cost of doing it through us versus the cost of getting street ketamine. You would go with the street ketamine, right? Like, because our cost includes all the preparation and integration and the tech and all the pharmacy fees and all those things like that. So it's just, the at-home model. Yes, like Ben said, in theory, there has been abuse with certain forms, but there are certain forms that, there are people who do send out, lozenges maybe for follow-up to inpatient, and they send a much larger dose. Like they'll either send a higher dose or they'll send a larger number of tablets, where we're really conscious about starting at low doses and sending a controlled number of tablets so that doesn't happen.
Wonderful. Got some good questions there. So I'll come to those in just a second, folks. And yeah, keep them coming. I wanted to ask a question around, I guess, safety. And there have been articles that have come out around, concerns around prescribing practices. There's also the piece around what patients is at-home ketamine for, what patients is it maybe not for. And you said, some patients might be best suited going to a clinic that does IV, IM, just that in-person piece, if they're able to. But can we talk about, like, what are some of the diagnoses that you're working with in particular? So what is ketamine indicated for, kind of using your protocols? And then what might be some either diagnoses, contraindications, or other kind of conflicts that might say this client, for whatever reason, isn't a good candidate for at-home ketamine therapy?
I'm happy to take part of it, and sort of curious, Lauren, what some of your experiences have been. I feel like there's still a lot of learning to be done on this topic, just to be really honest about it. And I think also it's best when one acknowledges that you are doing something in the realm of early adoption, as was sort of what we label this kinds of treatment. I mean, one could argue that this has been done now for over a decade, but at the same time, at the scale that we're doing it is sort of new. But if you're going to do any kind of early adoption of any treatment, then you want to be on the conservative side. And so we've really, I think also we were saying in our previous conversation, David, we've taken the approach of being really selective about, who is screened in. And so somebody who is identified as a higher risk person, and Lauren could maybe give some examples of people that are higher risk, but they're generally screened out. Like we just say, look, you might be a good candidate for ketamine, but not at the home base model. And and the things that we're sort of learning, I would say around this is that even though we screen out severe trauma or unsupported trauma or sort of people who have actually just started processing their trauma and haven't done a lot of work yet on it, we will screen these people out. There are some people in the realm of moderate trauma that we sometimes find need additional help as well. And that's something that we've been learning to try to identify early and say, hey, wait, let's make sure we really get you a good therapist in place so that you can actually do that kind of the higher touch in-person work in complement to this. And so sometimes we're able to make it work, and other times we just realize, okay, this model's just not going to work for everyone. But at the end of the day, it's doing what reassures us, and probably what keeps our adverse events to next to zero, pretty close to zero, is the fact that we're screening so rigorously up front. And the process of screening is not just one person. It's not just you meeting your medical provider. It's actually, it starts with asking the sort of common questions that we should be asking up front, and asking them multiple times over, like once digitally, then again through our welcome team. And then if we get any sense that there's somebody of higher risk, then they may have answered a question that we consider that should be flagged, and we should dive into it more than we, before them even having an appointment with a medical provider, with a prescriber, that they're actually speaking to a licensed nurse to dive into more detail that question before we even schedule that appointment. And so we have a very rigorous process before someone actually ends up receiving a prescription. Lauren, do you want to say a little more about your experience?
Yeah, so I mean, like Ben said, we've created these like medical protocols that really kind of try to consider all the different unique situations in which patients may be seeking ketamine. But then we also look at their medical history. So even though ketamine is inherently safe, right, it's, like we talked about how it has very minimal side effects, but then also it's just very well tolerated. And it doesn't negatively impact the heart and lungs, which I'm not sure that we talked about it that much earlier, but I just really like to emphasize that point. Part of the reason why they like to use it in anesthesiology is that it doesn't block that respiratory drive, which makes it so incredibly safe to do it at home with the somewhat minimal supervision, right? So you are never alone. You have your person sitting with you, but part of the process of deciding whether or not you're a good fit for the program, we kind of have like this protocol that we follow. We really want to figure out, well, number one, like why do you want to do this? Because some people will say, oh, I've heard ketamine might help with this. And then it's a conversation of, well, this is kind of a newer field and we're all kind of in this like experiment, right? We don't actually know if it's going to help. Like we don't have the data. We're working on it. We're collecting it. But we can't say for sure. And so, some of the patients, if they also have like, if they're I think the biggest thing is probably depression, anxiety, and PTSD. Those are probably our three major diagnoses that we're really working on. We have existential crisis, for people who are looking for like spiritual growth, spiritual insight, that's kind of the way that we address that. That is another thing that we can really kind of help support people through. But when we're doing the intake process, we're looking at, what are your goals and are they obtainable? Because I would hate for someone to say like, I'm looking for, like this, they watch like a documentary or they read on Reddit, like Reddit, every day someone asks me about something they read on Reddit. And so I feel like I need to start looking at Reddit because they have so much information there. but they'll talk about like these experiences that are just so transformational, and they're like, oh, I want my first dose to just like be a super high dose, and I want this and I want this, and when they're already coming into the medical consult telling me that they expect these things, it's kind of like a red flag for me, because I want to make sure that they're safe. We have strict protocols in terms of safety thresholds and the medical guidelines, like the dosing that we do. So there's a certain max dose that we prescribe. And if I feel like you're not going to get the experience you want at the dose that's within our parameters, then I just say upfront, I don't think this is the best fit for you. The other thing that we kind of consider is blood pressure. We consider people with sleep apnea, anyone who doesn't have any stable medical condition. We're going to revisit whether or not it's safe for you to do this treatment at home, despite ketamine being safe. And in the long run, when we consider, how many doses we're giving compared to maybe what someone's taking, if someone's drinking a lot every day, or if they're taking, really high, like controlled substances, if they're on Adderall and Ritalin and benzos and like all these kind of combination of things, we kind of think about how does that play into what kind of experience you're going to have as well. Some people are on so many medications. I worry, are you going to be able to have the experience that you're hoping for, given, your history and all the medications that you're taking? So we have that kind of conversation. We always talk about the support. What's your support like? Who is going to be there to support you throughout this process? If my patients are like, no one supports me, my psychiatrist thinks it's a bad idea, my best friend thinks it's a bad idea, my husband doesn't want me to do it, whatever, well, then I really don't think you're the best for the at-home program. Ketamine might help you, but I really think that you need to be doing it in person. People that have really high pain, they just tend to need higher doses of things. And so if they're coming and they're like, I really want ketamine to help me with my pain, that's kind of a tricky subject, because even though it's an analgesic and it is going to help give you temporary pain, it's not going to give you long-term pain relief the same way that an IV ketamine pain infusion can give you. We also think about people who just in general are very not sensitive to medications, so they need higher doses. Those people that come and I need 10 times the dose of what you would normally give someone. I think about that before I'd agree to give them ketamine, because I don't want them to be disappointed. I want them to have a good experience, and I want them to get what they're hoping to get out of it. But if they are already coming and saying, I already need double the dose, I only have a certain amount that I can prescribe to you safely. And so I can't go past that. And so we have that conversation. So it's more than just what medical things do you have going on that might be contraindication. Another big thing is just no person with, pregnancy, breastfeeding. There has been some research that it's okay. I think it's an individual provider thing. At this point, we're not really accepting breastfeeding patients. Any psychosis, schizoaffective disorder, people that have multiple suicide attempts with active suicide ideation, those people are going to be a little bit too high risk to be doing ketamine at home with the minimal supervision model. So those are kind of the bigger things, but it's really kind of like this all-encompassing thing that we really look at each person individually to say, are you going to be successful with this at-home model? Because really we want you to be safe, and we really want you to have the best experience you can. And even though we have like the most amazing team ever, like we have a fantastic welcome team, we have the client success managers, all of the people that are also helping the providers really just kind of help support the patient. We're all there to really give everything we can, but if that's not enough, then we need you to make sure that you have the support of your psychiatrist and your therapist. So if you don't have those people on board, then, that might be something that we might request before deciding whether or not we're going to welcome you into the program.
Well, that was an amazingly well answered question, Lauren and team. That, tells us a lot about where that sweet spot is of the patients that can access maybe and then shouldn't. And some of those shouldn'ts we don't yet truly know, and there needs to be more research. And like you said, with breastfeeding patients as well, that might be something, or even folks with personality disorders, bipolar, or even schizophrenia. There's some research happening there. I've got a question. Ben, you're doing an amazing job at answering the questions for us back in the chat. Thank you. There's one I want to pull up here, and it's by one of our students, actually, Christine. Thanks for that. She's a student on our Vital course, and I'm going to shamelessly plug the webinar that she'll be moderating in 2 weeks. It's on December the 5th, and it's titled Death, Dying, and Psychedelics. So that is December the 5th, 12 to 1:30 EST. So you can register on psychedelicstoday.com/events. So Christine asks, and it's similar to what we're talking about here, are there any discussions around developing niche programs for your treatment with other conditions and indications? For example, alcohol use disorder, because that's being utilized by Awaken in England, and it's over here now in Canada, America, and Norway, or for end of life treatment, which is something that Christine works with, or for working with veterans, and particularly say complex PTSD or military sexual trauma. So any other than say the depression, PTSD, and anxiety, any other indications that you are seeing that it's helping folks with now, or that you hope to be able to, you believe it could be able to help in the future?
Well, David, I think part of their question is indications, and part of their question is like life experience groups. So like veteran isn't an indication, right? But veterans, definitely, we have a program for veterans. They get a discount and they are put in a cohort together. So when she asked that include group sessions, all of our preparation and integration takes place in groups. So once they start with a certain group, they follow through that group. So by the end, they have some cohesion with the group. And for our veterans program and for our frontline workers program, we found it important to keep cohorts with people with the same lived experience. And so like we have the veterans go through a cohort together, and we're actually in the process of starting one for survivors of sexual violence. And so there are people in the, in the veteran community that could be in the veteran one, or maybe MST survivors, military sexual trauma, that may want to be in that group. So those are niche programs that we do have, and we continue to develop more. And that is less that we need research on indications, and more that we know a lot of them are suffering from the indications we already treat: depression, PTSD, anxiety, et cetera. And it's just helpful to have them go together in a cohort. And very often we are so in, our desire is to help those groups so much that we give them a significant discount. The other things like alcohol use disorder, I think they stated this, that if you're currently, and by the way, you guys can correct me, but if you're currently actively abusing alcohol, this is something that makes you a better, like you said, with Awaken, that is an in-person indication. And so, like, you continue to say, and it continues to be true for every part of psychedelics, we need more research on all of these. So we're glad that Ben and the Dr. Sessa and the team at Awaken are doing that research in different areas. But there's, certain indications like current AUD that are higher acuity that we feel would be better in an in-person session.
Thanks, Lynn-Marie. Wonderful. And someone asked as well about chronic pain in particular. Is that something that you think at-home ketamine treatment has benefits for? And I'm on the advisory board for the ketamine task force as well with Kimberly. So that's something they're really looking at, amongst other indications, is chronic pain. And that's a huge comorbidity for folks, with depression and PTSD in particular. And it's kind of has a bilateral, causation as well. So yeah, chronic pain. What are your thoughts around this modality?
I mean, there's good research for ketamine's use for chronic pain, a few different indications of pain, such as chronic regional or complex regional pain syndrome is one of the strongest, some of the strongest body of research in treating that. Now, and there also is some for migraine, chronic migraine. Now, with these disorders, you'll find that a lot of the research indicates a different kind of dosing protocol. And these are mostly IV-based studies, as is true even with most of ketamine research in general. And I would say the frequency of dosing tends to be higher for those people as well. So as we see what we're offering through our platform now as a wonderful complement for people who are struggling with pain. But I don't think our protocols are necessarily lined up to reflect the research around this. So we don't really place that as an indication that we're aiming to treat effectively. That being said, the comorbidity of depression and anxiety with pain syndromes is quite high. And so what we do find with patients who have that, who have dual diagnoses of these, that they do receive benefit. And the benefit is more on the level of mood, as you would expect, but also is in terms of developing a new relationship with their pain. So if you are dealing with a chronic pain, like you begin to start to change your sense of perspective or how you make meaning of your pain or its role in your life. And people's pain scores tend to go down, not just because their mood has gotten better, but because they've reframed the relationship to how the pain ever came to be in their life and how it continues to exist. I know that Lauren's seen a lot of people with chronic pain, so do you want to say a little bit?
Yeah. So, like I mentioned earlier, I mean, for the at-home model, it really depends on your pain and how long you've had it, and it's very intertwined with what else is going on with you. We find that, I mean, I love my patients that will have their experience, and in their experience tracker, they say to me that their experience is like the most blissful part of their life because they have no pain, because it's a dissociative anesthetic. So, like, you don't really feel your body. So, they appreciate the break from the pain that is constantly kind of wearing on them, even if it's only for an hour. But anecdotally, I find that they say that a lot of times it helps decrease that pain for a few days afterwards. So it does depend. For people that have, you know, really chronic pain and they're on lots of other medications and maybe they're taking opiates or whatnot, and they're still not really getting good relief, I find that they need the longer, higher dose ketamine experiences intravenously. Those IVs tend to be anywhere between 2 to 3 hours long, and they're much higher. They're not necessarily to the psychedelic threshold, but they are used in that capacity. There has been some research to support that NMDA receptor blocking also kind of helps reboot the computer, so to speak, and it makes the opiates work more efficiently. So I do find that a lot of people that are even on like the Suboxone, they tend to be able to kind of taper off their medications because their pain is getting better, their depression's getting better, they're just feeling better overall. Another thing that we recommend is stretching and walking and getting outside. A big part of the NueLife vision is talking about, mind, body, spirit, lifestyle. And so we really recommend, getting outside in the morning, getting that blue light, making sure you're walking and just kind of just being gentle with yourself and figure out ways to slowly make improvements. That's also a big part of the integration process. So if one of your goals is to decrease pain and, so that you could go for a walk, or you could go I had one patient who their goal was just to make it to the mailbox every day. So it's like little things that really just make a world of difference for them. And it's been very effective. And I think it just is totally individualized. If they have that comorbid, depression or anxiety or other PTSD going along with it, then we can really see that big change and that shift in their pain.
Awesome. That was great. Thank you. It's so cool to hear about just the real world lived experience. It's so different in a sense to randomized control trials. Just when you hear about real people getting to the mailbox, that's great. Or just having a day without pain, huge. Or, like Ben was saying in our podcast on Tuesday, talking about someone getting out of the house that had agoraphobia, or kind of functioning with their family and getting a job again. I want to hear about your research, but not yet. I'm priming that question. I want to just come back to a couple of comments and questions. Christine mentioned in the chat that she is familiar with quite a lot of folks that have chronic pain. They use sublingual ketamine therapy to prolong the therapeutic benefit between the ketamine infusions that they have. So that's a really awesome kind of protocol, that IV, longer durations with the, kind of oral ketamine, being done, as required at home, just to kind of be able to function much better. I just love how that kind of protocol is happening in the real world. I'd love that to be studied. And then there was a question that Gary asked, and this is close to my heart and Psychedelic Today. Obviously, as much as we really love and value clinical research and the therapeutic models that are evolving, we also really strongly oppose the criminalization and prohibition of drugs and psychedelics and the war on drugs. So this question is asking, is NueLife open to working with clients whose goals fall under perhaps enhanced well-being or spiritual and psychological growth? So I guess what we're saying is, would I need to have a diagnosis of something in order to work with you? Or if I came in saying, hey, I just feel like there's more to life than meets the eye, or I need help just being happier or figuring out some parts of who I am. Would that be enough to work with you? Or, do I have to have PTSD, depression, anxiety diagnosis to access treatment?
I'm happy to take a stab at it. So I actually love the question because I think it really is the forward thought of what we need to convey to medical providers, to regulators, and so on. Roland Griffiths, who is, I think pretty much everybody in the psychedelic field knows who he is, because he has really paved the way with a lot of the research out of Johns Hopkins. He recently made a statement about how he felt that in some ways the research around psychedelics is a little bit off course, in his opinion. And maybe not off course, wasn't his words, but he felt like we needed to be paying more attention to this topic, the betterment of the well, and from the perspective of psychedelics as a spiritual tool to help people to make greater meaning in their lives. And so behind this question, I think, is a sentiment that many researchers feel, and that we too feel. However, the betterment of the well is not a DSM diagnosis or an ICD-9 or 10 code that we can actually use. And unfortunately, the setup of the healthcare system to make sure that both our prescribers and patients are protected and can ultimately one day be reimbursed has to do with the system that is in place. And there are a lot of hangups to those systems. I mean, you could talk to many psychiatrists who will say they are not a fan of the DSM. But the reality is it does give us a framework to protect each other. Now, do we have people coming to us for the indication of the betterment of the well? I'm sure we have people coming and asking for that, and we're finding that many of them have depressive and anxiety symptoms. So, I mean, it's hard to find anybody who doesn't these days, with the amount of sort of systemic trauma that is taking place, just the existential fears that are rising with the pandemic, with war, with just general instability in the world, that more and more it's no question that depression and anxiety is on the rise because of all of those circumstances. So I know I didn't really answer the question directly, but we do need to make sure that we're practicing in a prudent fashion, and that is protecting both our prescribers and our patients.
Just to add to that, if someone comes to me and they say that they're looking for like the spiritual, exploration or whatnot, I'll take the time to figure out what else might be going on in your life where I could find something that would potentially be able to be diagnosed. So, for example, I use a lot of acute stress disorder because we all kind of have acute stress. And a lot of times if you're like, oh, I really want to do some spiritual exploration. And I'm like, well, why? Like, why do you want to do that? Like, what's going on in your life that you want that? And then they'll be like, oh, well, this happened to me. I'm like, okay, you're just telling me that you have some trauma. So even if you think you're coming for a certain type of exploration, there's usually a root cause for that. So I feel like we can figure out, like what Ben was saying, like the real like underlying reason why you're looking for that, and help support you in that way.
Great. Thank you. I'll settle for that answer. I appreciate that. But no, I love how you're just saying that why, Lauren. That why, what's underneath that? And often we might not have asked that question of ourselves. And we are all dealing with so much. So we're all just swimming in trauma like a big bowl of soup. We're all in there right now, just kind of getting used to it. It's becoming normal, but it isn't. So helping ourselves and helping each other just to recognize that and have validation, and then be able to walk through getting out of that big bowl of trauma soup is so helpful. And yeah, I guess the at-home piece is really powerful for that. Loads of great questions. We'll come back to those. Keep them coming. Before we go there, I'm loving this, by the way. Before we go to the chats and the questions, tell us about the research that you did, that interviewed lots of people, took their, their data from their charts and pulled it together and aggregated it and developed those outcomes. Why did you want to do that? Kind of what does it represent in a sense for the burgeoning science of this new modality? And yeah, just talk about it as well as in the real world. What does it say about the kinds of people that you're helping and some of the outcomes that they're getting and how you're measuring those outcomes? So we'll spend a bit of time exploring that, please.
I'll start the discussion on that because I saw Carlos in the chat ask if our model allowed for ongoing data collection that could be analyzed downstream and used to indicate research question and partner with academic institutions. And it's yes, absolutely. That's why we have, we have an app and a provider portal. They work together. And so we're all about the data collection. And David, your question was, why would we want to do this kind of research? Well, there are places that are starting to provide psychedelic therapies as an insurance benefit, like Anthea, and they don't want to do that if there's no research. And so sublingual ketamine was an area that did not previously have a lot of research. And so Mindbloom put out the first, we put out the second. So now there are 2 studies out there that show the efficacy of sublingual ketamine. And the things that we studied were specifically treatment-resistant depression and anxiety. And in our patients that did the course of 6, we saw 64% of them had at least a 50% reduction in the severity of their depression or anxiety. So again, that's almost 2/3, 2 out of every 3 people were at least half, like the half of their depression or anxiety was, it was cut in half. Their symptoms were cut in half. Like this is significant because these are treatment resistant populations. That means they've tried a number of things and that haven't worked so well before. And so that was a significant benefit, but, I'll let them, the others expound more on the details, but it just really is important for us to have this, not only for, insurances to cover it, but as, somebody asked the telehealth legislation question in the chat, for us to prove to legislators that this can be done safely and that it's efficacious so that the laws continue to let us do this service, perform this service in the manner that we're performing it. And I'll hand it over to my compadres for more response on the research.
I mean, there's not much I really care to highlight that Lynn Marie already didn't cover. So the paper's there in the chat. I don't know, Lauren, was there anything you wanted to highlight?
I mean, just to piggyback off of that, I think, we have this amazing opportunity we're like at the forefront and we're collecting all this data and we're seeing it and we're seeing people's lives change. And to be able to create like these studies and to publish them, it's just going to help, break the stigma and get the acceptance and just to allow us to break down those barriers so that we can help more people. Because that's really what it's about. Like we need the research, even if we kind of know and we see it, being able to publish something and to say, well, here's the results. If this is what you're really looking for, here it is.
And I'd love to add that in the hundreds of people that we had given ketamine to in this format, there were no serious adverse events. There were some of the general of, some nausea, some dizziness, the kind of things that you would expect, but no serious adverse events. So that again proves not only do we have efficacy, but also the model is safe. And so I think that's just as important in getting insurance to cover and getting the laws to look kindly on it.
Awesome. Thank you for that. And there's another question that's similar to what we're exploring so far around, in a sense, data. You can use that for kind of proving the model efficacy, insurance reimbursement. There's also the question of the legality of telehealth ketamine therapy at home. Up until a few years ago, that wasn't possible. Then, we had COVID and now it is. So someone's asking about, have you taken that into account around possible changes in telehealth regulation that could come about, because of COVID restrictions and emergency declarations. So can you just give a bit of context about like what happened a couple of years ago and how that model changed? And you know, back in the old days, 3 years ago, you know, Mind Bloom started out as a New York City clinic. And then COVID happened and they shut down the clinic pretty much before they saw anyone, and then said, okay, we'll do it on telehealth because that's how they could deliver it. And look what happened. And so why is this now an option? And how are you planning around potential changes in regulations?
So what happened a few years ago? Well, I think maybe 2008 was the Ryan Haight law was passed, which said that for you to be prescribing a controlled substance to a patient, you had to see them something like once every 2 years. So that you could not just be prescribing to somebody you had never seen in person. And like you suggested, that once COVID started, there was a public health crisis exception that was made so that we could be giving these controlled substances. Ketamine is a Schedule III substance. We could be doing this via telehealth. And now they are currently deciding whether they're going to make that permanent or how long they're going to extend it. And so obviously that would affect our business. And so we have created something called the New Network. And this is something we had always planned on doing. Just we did it a little sooner than we would have because of this, perhaps the exception expiring. And the way that New Networks works, and this is also going to answer CJ's question in the Q&A. CJ, shout out to CJ and Theo Nurse, beloved member of the Psychedelic Medicine Association. But I know CJ is a provider, which means a prescriber. So there are people out there like Lauren who are prescribing, doctors, nurse practitioners, PAs. Anybody who is a prescriber can become a New Network partner, meaning that in everything that we've mentioned, you know, we have the welcome team give you a call. We do our preparation group. You know, somebody like Lauren does the actual, you know, medical intake and then decides on the dose. And then we do the integration and all the follow up with our customer or our customer success managers. All of that we can hand to somebody else who can prescribe, and they do Lauren's role. And so, you know, CJ, if you feel like, okay, there's patients that you see that would be good candidates for this, you can become a New Network provider, and then your patient has access to our app. You have access to our portal. We take care of all the back end, right? We're still doing the compounding pharmacy prescription sends to the patient. The patient gets our eye mask and our journal and their anti-nausea medicine, everything. The prescriber just does the role that Lauren discusses, which is that medical intake and deciding on the dose, and we take care of everything else. And that is our way that we're able to make this now even available to more states, because, you know, we were in, I think, already 13 states. Now we can be in 50 states if we're as we partner with providers in those states. So this will help us bring NueLife healing, you know, methodologies to more people, but also helps you as a prescriber have this option that you don't have to hand your patient over to us. You can work with us and partner with us in that. And then also that helps us, you know, in the Ryan Haight exemption going away world, that, you know, CJ has probably seen this patient in person before, and therefore that will no longer violate the telehealth rules if that exception goes away.
I just want to pause and take that in, Lynn-Marie, because that's huge. And I want to spend a moment, and feel free, Ben and Lauren, to add to that, just to impress upon people how huge that is for a few different reasons that pop into my head. One, it means that you folks at NueLife are saying you don't want to keep all the money for yourself and just retain kind of the monopoly on doing this. You actually just truly make it accessible for all the other folks around the country that are already doing this work with their clients, you know, in their clinic, to get the skills to join the platform so they can take this methodology, and you can handle the back end stress and complexity and maybe uncertainty, walk them through it, so they can just bring it into wherever they are in the world. It's just there. And for folks watching this, I've got to say, there's such a huge lack of prescribers right now in America, whether that's psychiatrists, nurse practitioners, PAs. In some states, psychologists can prescribe. There's wait lists of 6 months, and that's just for regular, you know, Western psychiatry. So imagine the level of need for ketamine assisted treatment to reach, you know, 350 million folks, or just the adults, 200 million people. That's going to take a decade to happen if it's not, I think, enfranchised to those providers in those networks, in the health systems, in the clinics that have already got caseloads of 100 or 1,000 clients. So I'm just loving what you're doing there, building the framework to do that. And I'm not I'm just saying that because I've worked on the front lines of this for a long time. It's going to save lives over the course of the next 10 years. So yeah, thank you.
And thanks for adding that, David. And something that I left off is that, as people might be watching this and thinking like, how can I help this? I'm not trained in ketamine. We provide the training. I went to medical school. We were not taught on how to dose ketamine or how to know who's included or excluded from certain protocols. We cover all that. We get you trained because absolutely, we just want this, like we said, our mission is so based around accessibility. And so this helps us be accessible to so many more patients and helps the providers who I've been there, right? We see patients, they're not getting better on their antidepressants or whatever. And we're out of options, or we thought we were. And then here's finally, there's a toolkit that gives them another option that can give both the provider and the patient some hope.
Mm.
And I just want to add too, we created this beautiful training program. But it also really does allow for, this partnership. And so anyone who's going to be joining it, you will not only learn how to prescribe the ketamine, but we also teach you how to respond to the experience trackers, how to, help patients talk about integration. It's more than just dosing. And then you are partnered with our team to help you. So if you do have questions and you're like, how should I dose this patient? Or how do I respond to this? We support that process. So you're not alone.
Thank you, Lauren. And you mentioned the word integration. So let's jump into that. A lot of people in traditional Western medical models of allopathic care, when you say, oh, do you provide integration? Or tell me about your integration practice. They're like, integration of what? So that doesn't exist. Even in psychiatry and mental health treatment, there's no really such thing as integration. There's aftercare and there's, other pieces, wraparound treatment and case management. So can you explain about how do you approach integration? How do you define it? How do you work with clients in just a real world way so that they can get it and kind of take ownership of their integration journey, their aftercare? What does that look like? Because it's not just about the medicine. That just kind of opens the doorway. And so as not to kind of just always come back to the medicine, just to return to oneself and maybe even that inner healing intelligence, if anyone could speak to some of those points.
To be devil's advocate, I'm gonna say something that probably many people in psychedelics might find a little bit controversial, which is actually when it comes to ketamine, we have a lot of good research that ketamine alone is actually quite effective, specifically for treatment-resistant depression. Do we here at NueLife, and do I personally believe that it should be given alone? No. But there's a lot of good research showing that it is effective and safe to do it that way. What I think a lot of us intuitively believe is when you actually pair it with a specific kind of therapy, and we're referring it to integration, and furthermore with helping people with the more bigger picture of who they are as human beings by addressing mind, body, and lifestyle through health coaching and other services that we provide through our app, that you actually can retain the benefits that you gain. When you look at the research on the biomedical model, meaning just ketamine alone, you do see that people actually relapse back into depression in a relatively short time frame with a great deal of frequency. So we actually are seeing in some studies now that people who are pairing this with this work will actually have retained benefits for longer. This sort of veers a little bit into the conversation of maintenance, which I'll say for maybe a little bit later, maintenance dosing. But what we offer in terms of integration support is a group telemodel. So we have integration specialists who are, like I was saying earlier, not necessarily trained therapists, but they're trained specifically in this modality of integration. They've demonstrated, been vetted as people who have demonstrated a strong personal connection and skill set to do this kind of work. We believe that that the group format actually lends to one of the spheres of wellness that needs to be improved for most people, and that is connection. So allowing people to actually have an opportunity to see that they're not alone in their suffering, and to also through the technology that we use, to have the ability to pair these people up selectively by group. So depending on their demographics or what it is that they're focusing on, we're hoping to use that capability of our service more and more as we grow and as people engage more in it. And I think we had mentioned that we do have groups specifically for veterans at this point. The structure of the groups initially tend to be a bit didactic. So there are actual topics that commonly come up for people early on in their ketamine experiences and psychedelic experiences in general that are, you know, they're frequent. And so we make sure to hit those topics early, so that people have something to discuss, first of all, so that there is a sort of a core focus of these groups initially. And then later, if people are doing sort of more touch-ins with integration providers, and it can become a little bit more personalized. But the health coaching aspect is one-on-one. And we believe that that kind of attention when it comes to really focusing on the lifestyle component is key to motivating people, to them feeling supported, to them being able to track their progress on how are they doing with their goals, with exercise, with diet, or you know, just the conversations that they need to have with their loved ones to sort of move forward. Those kinds of things are best one-on-one. So we have that sort of personal touch that takes place there. I don't know if I missed anything.
Did you talk about NuScore?
Go right ahead. Yes.
So NuScore is this amazing kind of algorithm, and basically when someone is part of our program, they create goals for themselves. So whether it's meditation or exercise or you know, just anything, any of their goal, whatever they need, mind, body, spirit. And it can actually, they create these goals that is in the app. And then every day they log in and they track their progress. So like if their goal is to, you know, take a 10-minute walk twice a week, they can click, I made that goal. And then it will give them an actual score so that the provider knows and the patient knows how they are doing overall in terms of reaching their goals. So that's kind of another way that we really help support the patient with the integration process. The health coaches also kind of create this little tab that goes over their individual goals. And then a lot of us as the medical providers will also kind of have our own internal goals. Like, you know, we talked about, I especially love when the patients, their little goals are like painting or drawing, because then they send you pictures and they'll be like, look at my psychedelic inspired art. And it's just beautiful, you know, like they send pictures. Like, it's just awesome to be a part of this beautiful journey and to feel so, it's like so humbling that they want to like share their like most intimate parts of their life with you. And they'll just like send us these little pictures via chat, and we'll see pictures of their family, and they'll be like, oh my gosh, the first time this weekend I went outside my house, and here's a picture of me outside my house. Thank you so much. You know, it's beautiful. It's truly beautiful. But so the NuScore is another way that we kind of are helping them track their progress. They know how they're doing. We know how they're doing. And that's something that we take into consideration when we're deciding, you know, are they good fits to maybe consider doing more ketamine? You know, are they doing the work? Are they working with their therapist? Are they going to see their psychiatrist? Are they hitting their goals that they set for themselves? Because if they're not, then it's a different conversation.
Thanks, Lauren. And maybe while we're touching on that, Ben, you mentioned maintenance dosing or the approach to maintenance, and we're in the home stretch. But I also want to swing back to the subject of stigma next. But Ben, anything around maintenance? And you know, Lauren was just talking about it there, kind of building that relationship and tuning into kind of where the client's at in their journey.
Yeah, and so as I was mentioning earlier, some people end up needing ongoing doses of ketamine to sort of maintain those benefits. I think a lot of research still needs to be done on this. And for one, there is a common statement I hear in the ketamine research community that we don't have a lot of data on long-term use of ketamine. I think what they're referring to is long-term use of ketamine in this way. We have a lot of data on people and who have received ketamine many times over at significantly higher doses, and I think it's really important to bring this up so that people could have some perspective on what are we talking about in dosing here. So ketamine is really commonly used in the OR and in the emergency room. And so the doses that they're using there tend to be up to 10 times what we're talking about here. So significantly higher. They're used in very fragile populations like the elderly and also in kids. And so we have decades of safety data on that. Now, do we have a lot of safety data on people receiving repeat doses of very, very low or arguably closer to what one would call close to a microdose of ketamine in relation to what's used in the ER/OR? No, but we're starting to develop that. And as we're starting to see in a recent study that I think it was actually partially done by the people from Numinous, another psychedelic company on IM ketamine, they actually looked at 7 months out of people who are receiving maintenance dosing, and that they actually had retained and improving benefits of continuing that. Now, do we actually believe that maintenance dosing is the way to approach it as the default for people? Absolutely not. We actually believe, and we say this very explicitly, we're one of the few ketamine companies, and again, we don't view ourselves as ketamine, but it is one of the main things that we're providing. But we're one of the companies that actually aims to not give you more ketamine. We want to find a way for you to find the tools of your life through integration, through health coaching, through all the different supportive services through the app to not need to use it. Now, do people have the option to continue to use it if they and their medical provider deem it, necessary? Yes, we do allow for that, but it's not something that we're pushing for or promoting. Who actually needs maintenance dosing is the big question in my mind. And I actually suspect from what I've seen in the research so far, which is mostly on treatment-resistant depression, that it is a minority of people within the treatment-resistant population. To what extent is that? I've heard a lot of in-house reporting from different ketamine centers that have been doing models like this, that it's somewhere between 10 and 20%. So this is it should be a small number of people that really need to get ongoing dosing, and it should be people with sort of severe backgrounds. But the other side to what we were saying about betterment to the well, or people who could benefit from sustained use here and there. Say you're somebody who had depression, you're in remission, and you have a stressor occur in your life, and rather than try to put a Band-Aid on it, you want to try to see if you could do some deep existential work to understand how to process your grief or your stress or so on. I see ketamine as that kind of tool for those people to prevent them from fully relapsing. And so there are a lot of different ways to view the idea of maintenance and what it might be used for and who it might be used for. But I think it's still an area that needs more research to say with a lot of confidence.
Thanks, Ben. Yeah, really subject specific, how it could indeed be helpful. Got just about enough time, I think, just to talk about stigma. It's a word that comes up when we talk about mental health, psychopharmacology, getting help, when we talk about psychedelics and ketamine as well. So how do you work with the system and prescribers, providers around talking about what you do and the stigma that is there, but also more just the average person that's coming for help thinking, I don't know much about this. Is it for me? I'm a bit scared about what might happen, when I have my first treatment, and kind of some of the misconceptions perhaps or fears that are there. If one of you could speak to that.
Lauren, I'll let you discuss what you cover with patients if the patients themselves have that fear. But I run the Psychedelic Medicine Association. It's our job, day in and day out to talk to clinicians about these substances. And, there are two different conversations. One is the people who've come from ketamine as an anesthetic, and I don't know that it does anything else. That's generally the older clinicians like myself, so old. And from the other standpoint, we have people who might just know it as a club drug. And so, or veterinary medicine, like those are the three kind of previous conceptions that people have about ketamine. And like with anything else with psychedelics, luckily we have research to debunk these myths, right? Like, okay, the myth is that it's only a horse tranquilizer. Nope, it's been used in humans for decades. It's like you said on the WHO's list of essential medicines for humans. And then you share, about the club, if it's a club drug that they're afraid of, well, yeah, many substances can be used clinically and can also be used like, again, we don't love the term recreationally, but let's say non-clinically. And, here's the data that has come out when used clinically. And then you can show the statistics. And my favorite statistic out of all of them, or my favorite finding, is its effect on those who are acutely suicidal, because that is something that, all these mental health conditions that are serious, the one that you can't come back from is if we have not appropriately treated somebody who's acutely suicidal, and ketamine's very good at that. Not, again, necessarily the at-home ketamine, but if we're just talking about ketamine as a substance, that's one of the things I rely on. And so usually with presenting people with data helps a lot.
Yeah, and for our patients that have a little bit of anxiety going into it, we have prep sessions. So before they sometimes even see the providers, they've already gone to an hour-long session where we're talking about how to take the medicine, what to expect, what does it feel like, what things might come up for you, and how to work through those feelings. So that's kind of like the first round. Then they see their clinician, and if the patient talks about that, we'll kind of adjust the dose appropriately to make sure that, we're not giving them a dose that would maybe feel overwhelming. And then after their first dose, we can really taper to decide, what's the next best steps for you, and making sure that they're feeling comfortable as they move throughout the whole process. They can go to their integration where they can talk about their experiences with their group and with their integration specialist. And then even sometimes they like to talk about their health coaches, about their experiences and their dosing. And then, if they need a little bit more kind of hand-holding, so to speak, then we provide that. We will do follow-ups with them to make sure we're really kind of getting to the root cause of why they feel that way, and figuring out from like a dosing perspective what we can do, but then also from a psychological perspective, how can we make you feel better supported? There are so many things that we really do to kind of make sure that patients kind of have the best, most positive experience that they can. And so we really do kind of figure out how to really support them in that way from all the different members of the team.
Beautiful. All right. Thanks for that, Lauren. Thank you, team at NueLife. Somehow we've just spoken for an hour and a half, and it just flew by. Really easy to chat. Well done. I enjoyed it. And it sounds like just from the questions in the chat box, everyone really appreciated hearing from you. So thanks everyone that was tuned in for the great questions. Really appreciate it. And yeah, I think Ben, you're raising your hand. Go ahead, mate.
I know that people gotta go, but I can't help but want to read just some of the quotes from the experience trackers. So these are filled out by patients after their experience. So I'm just gonna read one since I know everybody's signing off. So this is actually from this week. We usually pull one every week to just sort of keep us motivated. This has been a life-changing experience. I am not a doctor or a scientist. I don't know what happened, but I am a changed man after 50 years and countless cognitive therapy sessions. We see those all the time. Anyways, thank you all.
Yeah, it's lovely to end it with words of a client, of a patient. Thanks, Ben. Okay, folks, big thank you, Ben Medrano, Lauren Marchewka, Lynn Marie Morsky. What a pleasure. And thanks everyone for tuning in. Goodbye, everyone. God bless.